Thank you so much, both Tom and Kathy, and it's a privilege to be with all of the people up here and to be here at this meeting. I learned at a time when I started with intracapsular cataract surgery, and I just put on here, anywhere there's a star, it means that I went through that learning curve. And I'm not going to go through each one of these. What I'm going to talk to you about is how I got there. I have 4 of these slides for you to suffer through. One of the things that I think is so important is for you to decide a philosophy of what is your role in medicine. Is your role to take care of lots of people? Is it to be on the leading edge, which to me is a little bit the bleeding edge, and I've never had the confidence really to be there? Is it to be an early adopter? That was my plan, was to go somewhere where I was needed, where I did the first of this, the first of that, and then to research in a way that you decide when it's safe, when not to jump on the bandwagon and yet not eat its dust. And so some things, like for example, topical anesthesia, if someone could do it, if it's doable, I can do that. So I did that like a week after it was described. On the other hand, clear corneal incision, I waited 6 months for outcomes. Foldable lenses, I felt there wasn't a big reason to go from 5.2 to 4.8 or 4.6 like the way it was until there was clear corneal incision, so I missed a lot of the problems with early foldable lenses. I feel that it's not enough really to watch videos. Videos are hugely important, but sometimes to gain a new skill, it's worth actually going to someone else's OR. I retired from patient care after 30 years of practice. I finished my residency in 1983, and I stayed reading the literature, visiting people that I thought were doing a great job, reading the textbooks, looking at my own videos, such an important thing to Monday night quarterback. I had the privilege of, once I became an adjunct professor at Utah, going to the lab there when I had a question, working with Liliana Warner. That's how I've really come upon many of the things that I teach for complication management, was to actually go work in the lab and see what came of that. By the way, I have no financial interest in any of this, never really did. Maybe that was stupid on my part. I never actually was paid to be a consultant. I had unrestricted grant money to study things from various places. I think that so much of this has to do with a degree of where you see yourself. And I think to be ethical, you either have to continue to keep up with the things that seem worthwhile, or you have to refer to those people that do it when you see a patient that needs those things. And that's something that isn't really that much part of our medical culture. You know, people do what they do, and that's what they offer, and that's what they do. And this is a place where I've heard people say, you know, well, maybe if a patient has glaucoma and they need a cataract, they deserve to have a MIGS. This is their one chance. So if you don't do it, perhaps you shouldn't do cataract glaucoma. You know, perhaps that's not appropriate. I don't know, but I saw it that way. I was very frank with patients. One of the reasons that I was able to do so many of these things is that I went somewhere where I was really needed, where it was 50 miles to the University of Iowa. I grew up on cement in Manhattan and chose to work in Iowa because I was needed there. And so I was able to say to patients, you know, I feel I have the skill set to bring to the table for this, but there are people who do this day in, day out. That's all they do, and I'm happy to send you there for either a second opinion or to be cared for, and I'll still take care of you at home when it's over, and it's up to you whether you want to stay or not. So that let me feel comfortable going to try new things because I had buy-in from patients who were sort of part of that journey in a way. I think that a lot has to do with, you know, a conservative is a liberal who's been mugged. And so a lot has to do with setting yourself up to have positive outcomes. Because when you have a problem, when you have a bad complication, when you have a patient who doesn't do well, you have to decide how are you going to psychiatrically handle that, yourself, and you have to feel for that person. And I've always tried to put myself in that person's shoes. What would I do if it were I took care of my mom, my mother-in-law is only my husband was my very last patient, actually, and not a HIPAA violation, he's allowed me to say so. I hope that this inspires you to consider that it can be such an exciting career if you don't just stick with what you do, but you evaluate what's out there, you learn how to do it. I've been teaching despite the fact my plan was a 30-year plan, and I was one of the values of going somewhere where you're needed. I did 40 to 60 cases a week the month I quit. I mean, that was my volume when I stopped, and it was a 30-year plan for me. And as long as I feel that I'm still contributing, I love teaching, I stay abreast of all of this, and I coach. If you want, you can call me and I can come to your OR and be a fly on the wall and talk about it later. I think we do need coaches. I think some of the people who retire from practice really would really make a huge contribution if they would help people with their skills and their knowledge and their presence even. So I just wanted to maybe have you think that these are great things to do. Read the literature, collect meaningful data to make informed decisions and assess your own outcomes. Those who don't count. Things are anecdotal in a busy private practice, at least they were for me. I didn't have research that I could do on my own, so I had to look at other people's. Visit experts whenever possible. Consider hiring a coach. Reap the benefits of giving patients the most up-to-date quality care, and you will enjoy your professional life immensely, as I have. Thank you for the opportunity to talk to you.